We are fortunate that we have a number of highly effective ALK inhibitors available for our patients today. Alectinib, very effective, very tolerable, 4 pills twice a day in the United States. Brigatinib, very effective, very tolerable for the vast majority of patients, 1 pill daily. And we know those are first-line options based on randomized trials. Ceritinib, available, a little bit more toxicity, so I'm not sure it's as enthusiastically adopted as a first-line option. And now lorlatinib, which we know is really good at overcoming resistance, is an FDA-approved option for overcoming resistance. Should we move this potent drug that can, in fact, overcome and even prevent resistance, should we move it up front? In my clinical experience, I have some patients who love this drug and have very few side effects. And I have other patients, and quite a few patients, I think, who struggle with it, who need a dose reduction because they have weight gain or aches or neurologic side effects, sometimes cholesterol problems. It is a drug that has some quirks, but an effective drug. I think, when you look at patient quality of life, alectinib and even brigatinib, these are drugs that I think are hard to beat, given that when patients get on them, they feel great. Lorlatinib is a little bit trickier. And so while I think it deserves to be studied, if I'm going to adopt it instead of alectinib or brigatinib, I would ideally want to see it randomized against alectinib or brigatinib to show that it's better than those drugs, rather than saving it as a resistance therapy where I think it has a very clear role. And so my sequence, I think, remains alectinib and hopefully, brigatinib in the first-line setting with lorlatinib as that backup plan.